Okay, recording.
Cool. So we'll mainly talk about lung ultrasound for COVID since we're back in the midst of COVID. But we'll talk a little bit about some other lung ultrasound pathologies as well. And we'll talk a little bit about the evidence, why we're using lung ultrasound in COVID, and how we're using it. And I thought maybe towards the end, or maybe you could even butt in while we're going along, but Anna and Michael might be able to give you their take on how they're using lung ultrasound in their departments. And then we'll talk a little bit about how we're actually going to do this lung ultrasound, how normal lung will appear, and then some of the features of COVID, and then how we're going to differentiate that from some of the other things that we used to look for before all we're seeing is COVID. So we start off by talking a little bit about where lung ultrasound has come from and some of the evidence. So it all kind of really started off with the publication of the Blue Protocol in 2008 by a chap called Daniel Lichtenstein. And this was a paper of essentially intensive care patients with acute respiratory distress, looking at the overall diagnostic accuracy of lung ultrasound. But what we've seen over the last kind of 10, 15 years is a established evidence base now, I think, for undifferentiated breathlessness, all causes of respiratory distress. And then we've also started to get some more literature on using lung ultrasound as part of a diuresis strategy or fluid resuscitation strategy. So using essentially lung water volume to either guide the amount of water we're giving or taking away. So this Blue Protocol, like I say, published in 2008, there's a retrospective case series of 260 patients using what is quite a complicated kind of structure for interpreting lung ultrasound, but achieved a diagnostic accuracy of more than 90% for all causes of respiratory failure. So this is pneumothorax, pulmonary edema, pneumonia, pulmonary embolism, and then airways disease, COPD, and asthma. But we're not really going to use the Blue Protocol. We're going to talk a little bit about another way to interpret your lung ultrasound when we get to that. Lung ultrasound is really probably the one modality where we have the most robust evidence, I think, and I imagine that Anna and Michael would agree. And particularly in the last couple of years, we've had some pretty good evidence in terms of point of care ultrasound coming out. So there was this study by Pivetta in 2019. So this was a randomized control trial in quite a lot of patients with decompensated or with suspected decompensated heart failure. And ultrasound had a better diagnostic accuracy than chest X-ray and BNP. And also a significantly shorter time to diagnosis. So better disposition, speedier disposition of patients with heart failure. When we look at some of the literature for all of the various causes of respiratory distress, what we see is ultrasound generally having a better sensitivity and specificity compared to chest X-ray for pretty much every cause of respiratory failure. And this is some of the data, some of the combined data comparing either ultrasound or chest X-ray to CT or final diagnosis as the reference standard. So what we know about lung ultrasound already before COVID is that we've got a modality that has basically a better diagnostic accuracy than chest X-ray. Which brings us on to why we've just started to using COVID before there was any literature available. Well, if we know that it's working for other causes of respiratory distress, and that includes other viral pneumonias, so there's some evidence from previous pandemics, SARS, MERS, that's also pretty good. It means that we can use it for our patients with COVID-19. Lung ultrasound is probably the most simple point of care modality to teach, and what we know is that it's easily trainable. We can dispose of our patients earlier. we can actually just have a better diagnostic accuracy compared to some of our other tests. And we know that chest X-ray is between 60 and 70% sensitive, and a PCR test is only 70% sensitive for COVID-19. We could CT a lot of our patients, but I think ultrasound has a lot of logistical and infection control benefits compared to CT. And then the final thing is that really COVID is the ideal respiratory disease for ultrasound, because a lot of the changes that we're seeing are peripheral changes. So we get good images of the peripheral lung. We don't get so good images of the deeper parts of the lung. So COVID really lends itself quite well to using ultrasound. With limited evidence, it's difficult to say really how best to use it. And like I say, I'm sure Anna and Michael will have some comments on this. And I know that, Anna, you've had that study where you've been using lung ultrasound to stream patients coming off the ambulance. But in general, I think where I'm using it most is in the patients with an indeterminate chest X-ray, in patients that have lots of respiratory and cardiac comorbidities, and then in patients where there's a high clinical suspicion, so fever and cough, for instance, but a negative initial PCR. And then there's a whole group of patients that you already know have COVID, but perhaps they're a little bit more hypoxic than you'd expect. And ultrasound can be very, very helpful in trying to stratify those patients who you think may have a concurrent PE. So for instance, we've had a few patients here that we've suspected COVID. They've been really hypoxic, SATs in their 60s or 70s. And then looking at their lungs, the burden of kind of COVID lung changes has been much smaller than I would have thought. And that's pointed us in the direction of looking further for a PE. And like I say, we've had a few cases like that. If we're just going by the evidence, really the only role that we can be quite clear about is that if you integrate lung ultrasound with your clinical assessment, you're going to improve your diagnostic accuracy. Looking at some of that evidence, of course it's limited. This is a relatively new disease, although I guess not so new now. And the literature has improved over time, but still we're left mainly with small retrospective studies and convenient sampled studies. So essentially it's mainly studies of symptomatic patients with respiratory complications of COVID. So none of their kind of non-pulmonary manifestations, asymptomatic patients, all comers, so including, everybody that books in at the front door. So we know very little about that. But what we do know is that it's a much more sensitive test compared to X-ray and PCR. We know that the findings on chest X-ray correlate with CT quite well. And CT is, I think, probably the best gold standard reference test we have at the moment. And there's certainly data to suggest that it's going to be useful in disease monitoring and estimating disease severity. So those things are maybe more important if you're an acute medic or intensive care. But for us at the front door, we know that we're going to improve our diagnostic yield if we're adding lung ultrasound to the rest of our assessment. And I don't think lung ultrasound is an alternative to X-ray. I think it's an adjunct to X-ray. So myself and Michael have done a fair bit of work on looking at the literature. And at the moment, there are 15 reasonable studies looking at diagnostic accuracy, comparing lung ultrasound to PCR or CT. There are some studies looking at a final clinical diagnosis. And in the majority of these studies, what we've seen is a very high sensitivity, more than 90% sensitive in 10 of the 15 studies, but a much lower specificity. We think that sensitivity is most likely going to be related to training and scan techniques. So experienced practitioners more likely to pick up more lung ultrasound changes. And we think that the low specificity is actually in part due to the low sensitivity of PCR. So if you can get your head around that, if your PCR is negative and you're comparing your lung ultrasound to a negative PCR, then this is going to affect the specificity of your lung ultrasound. A couple of things really when we're looking at the literature for COVID-19. The data is quite low quality. There isn't really an agreed reference standard, and at the same time we're looking at our data during a time of really high disease prevalence, and that's really going to affect the diagnostic accuracy of any test. As we've come towards the second wave, we've had a couple of larger, slightly better quality studies published. So this first one by Lieveld, that was one of the first prospective studies. It's multi-centered and blinded. A fair number of patients. Again, most of those patients are respiratory patients, so patients they've presented with pulmonary manifestations of COVID. But they've achieved quite a high sensitivity, quite a high specificity, higher sensitivity than CT, and pretty comparable specificity. And I think importantly, none of the patients in that study that had a false negative ultrasound required admission for oxygen therapy. So that would suggest that anybody with significant disease requiring admission or oxygen would have a positive lung ultrasound. So I guess in our sicker patients that need admission, the sensitivity has creeped towards 100%. Another larger study, another prospective study. So we've seen this group of authors before when we were looking at that heart failure study, but they've published just recently too, again, achieving quite high sensitivity and specificity. And a pretty neat finding in this study was that for 21 of their patients that had a negative first PCR test and then a second positive PCR test, their initial lung ultrasound was already positive. So if you think about integrating lung ultrasound with PCR clinical assessment, you'd be really pushing your diagnostic accuracy quite high. Moving on to how we're actually going to do this lung ultrasound, there's a lot of ways you can go about this. The more systematic you are, the more likely you are to catch the changes. And I think that's the headline to take away. Given that our patients are often quite sick, often quite hypoxic and positionally dependent, scanning can be quite challenging. You can choose to scan them sitting forwards. You can ask them to cross their arms to spread the scapulae, and that will give you more space posteriorly. You can also scan them lying down, either supine or prone. That doesn't really matter so long as you're getting good coverage of the thorax. I tend to use the curvilinear probe for all of my lung ultrasound, and essentially, although the linear probe will give you that high frequency, high resolution image of the pleura, it doesn't have the penetration necessarily to see deeper pathology in the lung. So the larger areas of consolidation, lobar consolidation, you may miss with a linear probe, but more likely to see with the curvilinear. And I still think the curvilinear gives you enough resolution of the pleural line to see pleural line abnormalities. So for the most part, I stick with the curvilinear. You will see some images that have been taken with a linear probe. And I guess if you're just looking for a pneumothorax with your ultrasound, you may choose to use the linear probe because you're going to get a really high definition picture of that pleural line. Ideally, we're going to we'll start by using a lung preset. So most of the contemporary cart-based machines will have a whole load of presets. As Anna has alluded to, a lot of lung ultrasound is all about picking up artifacts, and that's why we want to use this lung preset. So this is a preset that doesn't remove artifacts from the image, whereas other presets will remove what the machine has determined to be an artifact. If you don't have a whole load of presets and you don't have a lung preset, you can just use an abdominal preset, or you can turn off your tissue harmonics and change your post-image processing. But I don't think that's anything to dwell on today, because most of you will have a contemporary machine in your department. We're going to set the depth between 8 and 10 centimeters pretty much. You may want to increase that or decrease that depending on the size of your patient. But ideally you want the pleural line in the center of the image, and you want to adjust the focal zone to the pleural line. So the pleural line is going to be the clearest part of the image, and as you diverge away from that pleural line, your image is going to lose resolution. Your probe can be placed either perpendicular or parallel to the ribs, and we'll come on to that in a moment. So, no, they're not playing. So video is not playing. Excellent start. So on the right of the screen here, you've got the probe placed perpendicular to the ribs. So you're going to have an upper rib and a lower rib in your screen, and you're going to have this pleural line in between, and what is the kind of lung space behind, although this isn't lung tissue, because all of that ultrasound has been reflected off that pleural line. Less commonly, you'll see people scan the lung parallel to a rib. So you're going to increase the amount of pleural space, but at the expense of potentially misinterpreting the pleural line, because you don't have those ribs as a sonographic landmark. For COVID, there hasn't been a validated scanning protocol. There are lots of other well-validated protocols used in lung ultrasound, and you can use any one of them, to be honest. I think that the take-home is just to be comprehensive, because changes in COVID are, as you know, bilateral and patchy. And if you're looking for patchy changes, then you're going to need to scan a lot more of the lungs than a diffuse disease such as pulmonary edema. And remember to try and scan those dependent lung zones, because they're the most commonly affected parts of the lung in COVID-19. So I tend to try and stick to a 12 zone protocol myself. So 2 anterior, 2 lateral, and then 2 posterior zones. I don't necessarily scan 12 individual points of a lung. I'll tend to scan more like this. So I'll go down from the first or second rib space all the way down the anterior chest, all the way down the lateral chest, and do the same posteriorly. And this video here on the left will show you an image of me just going down rib spaces from head to foot. And then on the right here is the lawnmower technique. So this is probe parallel to the ribs in the pleural space. And then, as you can see in that video, I'm just sliding across a intercostal space, coming down a space and sliding back across. And the lawnmower technique is probably the most comprehensive, because you're scanning all the way through each rib space. We'll have a quick talk about normal lung. So here we've got probe positioned perpendicular to the ribs, and you will see an image that has 2 ribs, so an upper rib and a lower rib, with a posterior acoustic shadow behind each rib. You'll have a bright pleural line, and the shape made by the 2 ribs and the pleural line you may see referred to as the bat sign. And then you have these bright reverberation artifacts behind the pleural line, equally spaced, and those are the A lines. So soft tissues, those are your ribs and your pleural line making the bat sign. And then you've got ribs and you've got rib shadows. Anna has already touched on A lines, but we'll kind of go through those again. These are things that we're going to see quite often. And it all lends itself to the echo range principle. So you have an ultrasound beam that's coming away from the probe, hitting the pleural line and reflecting back. And the time that takes is going to then plot one line at a certain distance away from the probe. Because the probe and the pleural line are so reflective, that same wave will bounce back to the pleural line and back again. The time that that has now taken to come back to the probe is double the first amount of time. So you get another you get another line as a reverberation artifact, and so on and so on. So you get multiple A lines going through the image. Here we've got a video of normal lung. So you're going to see some lung sliding at the pleura. You'll see some comet tail artifacts. So these are small bleb-like artifacts that just extend a few millimeters from the pleural line. You'll see some A lines, but this is normal lung. So just here, you see a comet tail artifact, and you can see that this pleura is moving back and forth. And this distance here, you can see has doubled to this point where you get that first A line. Posteriorly, we'll see the lung curtain. So this is, again, this is part of the normal lung appearance. And as we get down to the diaphragm, you'll see normal lung coming in over the liver, and that's the lung curtain. And if you can see a lung curtain, it means that you don't have a pleural effusion. And then this is a more traditional view that you should all be used to, or at least those of you that have done your level 1 or are doing your level 1. So this is the kind of right upper quadrant, but we've moved slightly more towards the head to get that Costophrenic angle in and that lung base. And you can see here that we've got that mirror sign that Anna has spoken about across the diaphragm here. And I'll just point out that we can see some vertebral bodies just here, and that will end at the diaphragm. So you will not see vertebral bodies beyond the diaphragm, and that's because the air-filled lung has essentially reflected all of that ultrasound back. The change in acoustic impedance stops that ultrasound beam getting towards the thoracic vertebrae. And if we see vertebrae extending beyond the diaphragm, it means there is something pathological creating an acoustic window in the thorax. So moving on to what we're going to see in COVID, we'll start by having a quick think about what we actually see on kind of conventional imaging. So we see these ground glass opacities on CT, and they're very, very common. Less commonly, we see consolidation, and then less commonly still, we see pleural effusions. And most often we see that the changes are bilateral and they're multifocal. Rather than diffuse, they're multifocal. So you'll see discrete areas bilaterally with changes, less likely to be diffuse like in pulmonary edema. So our ultrasound findings, so B lines, that's the thing we're going to see most commonly, although that's the least specific of the signs for COVID-19. We're going to see B lines in around 80 to 90% of our patients with respiratory symptoms. And we're going to see those typically in more than half of the zones that we scan. Second most common, we're going to see a thickened or irregular pleural line. We're going to see that in roughly 60% of our patients. Less commonly, we'll see the sub-pleural consolidation, and I prefer to call that peripheral consolidation because by virtue of all consolidation being within the lung, it's all sub-pleural. So by sub-pleural, I mean peripheral. And then lobar consolidation we do see, but you see that quite uncommonly and mainly in severe disease. And then the least common thing to see is a kind of a standard bilateral, moderate or large volume effusion. But you can see small localized effusions around areas of peripheral consolidation in up to half of cases. Lots of these signs are non-specific. So we see lobar consolidation in bacterial pneumonia. We see B lines in heart failure. We can see subpleural consolidation in a pneumonia or an infarcted pulmonary embolus. But the key is the distribution of findings. So the patchy and bilateral nature of all 5 of these findings will help you differentiate between COVID-19 and other respiratory pathology. So we'll start with B lines. Here we've got a couple of COVID cases with B lines. So you see these long, bright white artifacts extending all the way from the pleural line. They eradicate the A line, so we see no A lines, and they extend the entire way down your image. So it doesn't matter how high you've set your depth, you will see a non-attenuating artifact from the pleural line. And the reason it's non-attenuating is because it's not the original ultrasound beam. As the original ultrasound beam hits this kind of tetrahedral formation of air and liquid at the pleural line, the original beam is reverberating within that column of fluid and creating its own beam away from the pleural line. So it's non-attenuating. And it's the B lines that represent the ground glass change on CT. So ground glass changes on CT are very common, B lines also very common. But like I say, non-specific. In this image down on the right bottom corner, we actually see a small localized pleural effusion around this thickened irregular pleural line with B lines. Pleural line abnormalities, again, quite common in COVID. And what we really mean here is either a really irregular or thickened pleural line. So ordinarily you're going to get a thin, bright white line. You may get some comet tail artifacts, but it won't be thick and it won't be irregular. So this looks quite messy and it looks quite thick. It certainly isn't smooth. And when it creeps out of the side of this rib shadow, it looks very, very irregular. The pleural line, though, should show ordinary lung sliding. Really sticky pleura can reduce lung sliding, but you should always see lung sliding in your COVID patients. So here again, we've got an irregular pleural line, possibly a sub-pleural consolidation here. And from that irregular line, you're also seeing B line. So we've got two COVID-like changes, both of them non-specific, but the constellation of the two is much more specific for COVID. So moving on to our peripheral consolidation. So this is a image taken parallel to the ribs, and you see this thickened irregular pleural line and then this chunk taken out of the pleura, and that's an area of consolidation here. And again, you see another example of a subpleural or peripheral consolidation here. Usually you'll get some B lines that start on the edge of that area of consolidation. You also likely to get some inflammatory fluid around there. And like I say, if you've got some really sticky consolidation near the pleural line, you may get reduced lung sliding. So this shows reduced lung sliding, but you can see it is still sliding. And this is common in all viral pneumonitis. This is the kind of thing you would have seen in flu a year ago, well, 2 years ago. Here's another couple of good examples. So here you can see a little area of peripheral consolidation sneaking out behind that rib there. And here's another slightly larger peripheral consolidation. And you get this almost torch-like waterfall of B line behind it. So there's an area of confluence of B lines coming from that peripheral consolidation there. This then, in severe cases, will extend to a lobar consolidation. So this is at the right base. So this is diaphragm here, and you're getting hepatisation of the lung here. So the lung is starting to look like there's similar texture to the liver, and you see some air bronchograms within that too. And then we've seen this already, but here again, you've got that anechoic localized pleural effusion. And then if you're seeing a moderate or large bilateral effusion, that would be very atypical for COVID. So that would make you less likely to think that these changes are from COVID. So if you had for instance, bilateral widespread diffuse B lines and bilateral large pleural effusions, that would push me towards heart failure rather than COVID-19. So thinking about how we're going to interpret our lung ultrasound images, we're going to take some images anteriorly, laterally, posteriorly. But we've already mentioned that a lot of these changes are non-specific, and you can get them in multiple pathologies. So here I've kind of just categorized what you are going to see and what you're not going to see in each of our kind of commonly seen respiratory diseases, and what you can see from this is that there's lots of overlap, but the key is in the distribution of these changes. So in a viral pneumonitis, you're going to get bilateral patchy changes, and although you'd see B lines in pulmonary edema, this is going to be more diffuse, and it's not going to have consolidative changes, and it's going to have a normal pleural line. In a bacterial pneumonia, again, you may see B lines. You're certainly going to see consolidative change, but it's going to be unilateral and focal. So whenever you're looking at all of your ultrasound images, after you've done a scan, just think about where you're seeing the changes and how they're distributed. And that's going to help you with your differential diagnosis. We spoke about the blue protocol and how complicated that can be if you try and use that with all the PLAPS points and all of those things. But Michael has his Trauer approach, and I think that's probably the most simple way to look at it, actually. If you start by looking at the pleural line, then you start looking at A lines and B lines, and then consolidation, and then effusion. And then if you combine that with the distribution of each of the findings in those four categories, you can start to hone down your differential. So you'll start by looking at that pleural line. Is there lung sliding? Is that line smooth or irregular? And you might think about whether there's a lung pulse, and we may talk about the lung pulse towards the end. And then once you've decided whether there's some lung sliding and whether that pleural line looks smooth or irregular, you're going to look for some A lines. And if there are no A lines, have they been eradicated by B lines? And if there are B lines, are they focal, diffuse, unilateral, bilateral? And are they confluent? And confluent B lines is a marker of severity. So confluent B lines in heart failure, for instance, would tell you that that's a much higher burden of interstitial fluid than if there were just 3 or 4 B lines in each zone. And then we'll look to see if there's any consolidative change, so whether there's any peripheral or sub-pleural consolidation, or whether we're seeing some lobar consolidation. And then finally, we'll look for effusions and whether these are dependent, whether they're localized effusions, and again, whether they're unilateral, bilateral, and how large they are, because we're not going to see large effusions in COVID. We're going to see large effusions in patients with heart failure or hypoalbuminemia. So COVID's quite simple. You're going to look for some B lines. You're going to look at that pleural line. You may see some effusions. But I think PoCUS doesn't really stop with the lung ultrasound in COVID. I think there's certainly a lot more we can do. And I don't think a lung ultrasound really goes without an echo, particularly if you're seeing B lines and you're worried about heart failure or COVID. So you may look for evidence of myocarditis and global reduced cardiac function, and you might think about doing an echo or a DVT scan if you're worried about PE. And certainly a DVT scan is very specific for an acute PE in patients where you suspect that. We'll just go through some of the other common stuff because I don't want to obsess with COVID, and we sort of need to know what the other stuff is going to look like if we're going to differentiate between COVID and some of our other lung pathologies. So pneumothorax, we're going to look for lung sliding. We're going to look for the absence of lung sliding. We can turn the M mode on and look for the barcode sign, which is a sign of pneumothorax. And and we can look for the lung point. So the absence of lung sliding is very sensitive. So if there's no lung sliding, it's very highly likely that we're going to pick up a pneumothorax. But we only know that it's definitely a pneumothorax if we see the lung point. Thinking about why we don't see lung sliding in pneumothorax, that's essentially because there's a space of air between the parietal and visceral pleura. And ordinarily when those two pleural surfaces are together and the lungs are inflating, we see that movement between the two. If there's a layer of air between them, then all of that ultrasound beam is going to reflect off that air before we see that visceral pleura moving with lung inflation. And the lungs will still inflate even if there's a pneumothorax, we just won't see it. So in this video, we're seeing an absence of lung sliding. There's some movement of my hand, but this pleural line is smooth and not moving from side to side. So there's no shimmering of that line. There's no ants marching along. That is a pneumothorax. Comparing that to the other side, in the same patient, you can actually see there's some comet tails, and those comet tails are moving along. So that shimmering appearance of a moving pleura. If we put MO through, so as Anna's mentioned, so this is the motion mode, and we're going to look at all of the information along this one scan line, and we're going to look at that over time. So the x-axis is time and the y-axis is depth. So the soft tissues here are not moving, and we see just a series of straight lines. Then we see the pleural line here, which is slightly brighter, and the lung behind it, which is moving, and we see this Seashore sign. So over time, we're seeing the Seashore sign. In the absence of lung sliding, where nothing is moving, we just see a whole series of straight lines, and this is the Stratosphere or barcode sign. The lung point represents the point at which the lung has re-expanded, and this is highly specific. So this is essentially 100% specific for a pneumothorax. So let's say you picked up a pneumothorax anteriorly here, so you didn't see any lung sliding. You could follow that rib space all the way around to the lung point and be certain that what you're seeing is a pneumothorax. And this is what it looks like here. So we've got pneumothorax here, and then this is where that lung is re-expanded, and those two pleural lines have come back together. This is probably the disease that is most confusing when it comes to COVID, because we see lots of B lines in COVID, and lots of the patients that are admitted with respiratory complications of COVID also have lots of comorbidities that will include heart failure in a lot of them. And before COVID, we used to think of B lines pretty much in terms of pulmonary edema. And you know, you would occasionally see some unilateral focal B lines in bacterial pneumonias. Essentially, two B lines in one lung window can be normal. All of us will have one or two B lines in the dependent lung zones from atelectasis, for instance. But more than 3 lines in one zone is abnormal, and more than 3 lines in more than 2 zones bilaterally we would used to have considered indicative of diffuse interstitial syndrome. Of course, COVID does not necessarily need to be diffuse, but in the context of heart failure, that would have been our definition. In heart failure, what we're going to see though is a really crisp, smooth pleural line, and that's really going to help distinguish between our COVID patients and our heart failure patients. So here are a couple of cases of non-COVID B lines, and you'll see that that pleural line is not thickened and it's not irregular. So on the left here, we've got a nice smooth pleural line, no sub-pleural consolidation, no irregular pleura, and we're seeing these B lines coming from the pleura non-attenuating all the way down the image. And then on the right here, this is a patient who'd had a STEMI, hypoxic, has presented on the 30th of December, so right in the middle of COVID, with breathlessness. And that smooth pleural line, really diffuse B lines, makes this more likely to be pulmonary edema than COVID. This is some B lines in another heart failure patient using the linear probe, so slightly better resolution of the pleura, but the B lines will be visible just the same as with the curvilinear probe. They're non-attenuating, they're extending all the way down that lung image. Here we see some confluent B lines just in this middle window here. And then I think we've got one more example of confluent B lines. And again, this is a heart failure patient, and we see a nice, crisp, smooth pleural line. Moving on to bacterial pneumonias. So we will see much more focal unilateral changes. You'll see some unilateral B lines, often emanating from the area of consolidation. You'll see that the consolidated lung, instead of looking grey, as it would in the normal image, has started to look like tissue, and that's called hepatisation. So it's starting to look like the liver. You may also come across this term, the shred sign, and this is a descriptive term to describe the border between normal and consolidated lung. And then you may see some air bronchograms. And again, sticky lung may reduce lung sliding locally. So this is that shred sign, and this is this shredded appearance between consolidated and normal lung. And we see it again here. So here's liver, diaphragm, and this shredded appearance between consolidated and normal lung. And you can see that there are some B lines coming away from the consolidated lung. We spoke about this briefly earlier, but here we've got some hepatized looking lung tissue here at the lung base, and we've also got a small anechoic effusion, and we're seeing vertebral bodies beyond the level of the diaphragm. So we can already tell, even though we're not seeing too much of this lung base, that there's a pathological process creating an acoustic window, allowing us to see these thoracic vertebral bodies, and that's a basal pneumonia there. Here we see some dynamic air bronchograms, and we see that hepatized lung tissue again. Moving on to effusions, this is the thing we're probably most used to looking at. Certainly we look for pneumothorax in our fast scan. So again, for those of you who have done a fair bit of core, this shouldn't be too alien to you at all. And we're looking for anechoic fluid at the lung base. We will not see the mirroring that we normally see. And again, the anechoic fluid is going to create an acoustic window for us to see those thoracic vertebral bodies. So in this schematic, if we're right down at the diaphragm, we're going to see that spine sign, and we're going to see some lung floating in anechoic fluid. And then as we come up the chest, we're going to see collapsed lung within fluid. Here we see another example of the spine sign. So diaphragm here, anechoic fluid, creating an acoustic window to see these vertebral bodies. And here again, we see another pleural effusion. And another one here where we see the spine sign. We see some collapsed lung within that anechoic fluid. And this is more likely to be an exudative pleural effusion, given its appearance. One last thing to say about pleural effusions, just because you may see this term in the literature, so this quad sign, and that's essentially a a quadrangle created by the two rib shadows, the parietal pleura and the visceral pleura. And that's how some people would describe a pleural effusion in the literature. You may also come across this sinusoid sign. So if you put M mode through a pleural effusion, you're going to get this first characteristic part of the M mode image. You'll see the anechoic effusion, and then you'll see over time the lung within that effusion ventilating. And here's an example of that there. In terms of our other pathologies, so we've talked about COVID and we've talked about bacterial pneumonias, we've talked about effusions, pulmonary edema. You then have a few lung pathologies that will essentially turn up a normal lung ultrasound. So COPD and asthma, you're very likely to get a completely normal lung ultrasound. In COPD patients with bully, you may see some small areas where there is no lung sliding, but essentially that will be normal. And again, in PE, where there's no parenchymal changes, unless you've got infarcted emboli, you're again going to see normal, normal lung. Any questions? I've kept to time, 10 to 9.
Well done, Ash. I like your mention of the Trauer approach. That was the highlight for me.
I'm sure it was.
You kept to time and you rhymed. I thought that was really good. Did you mention Volpicelli's light beam sign thingy?
I didn't mention the light beam.
I might just show that quickly, if that's all right.
Yeah.
So if you just unshare for a second. Since last time, so I've been writing our new SOP, and at Lewisham, as Ashley mentioned, we used it for streaming last time around. We were going in the back of the ambulance, and that was mostly because our green area, as it was at the time, which is our non-COVID area, was quite a vulnerable area. So we put our vulnerable patient staff there. B, we weren't allowed masks or PPE in that area at the time because it was quite scarce, and it was an open bay. It didn't have walls, so we had to be quite sure they were low risk. So we screened everyone with the ultrasound and put the ones where we were really quite sure they were negative there, because the other area had cubicles. So even if they were not having COVID, if they were a moderate risk and had something on ultrasound, we'd wanted to keep them away from the green area. So that was our reasoning behind it. So it won't work in every hospital. But since then, we sort of even things out a little bit. Obviously, they've got PPE in all areas now. And so what use does it have now? So like actually, I'd say it's just an extension of examination now, and you're just using it to build your case, really. We're having a lot of COVID with something else. COVID with someone, or breathlessness and feeling a bit achy with someone who we know is at very high risk for PE, or someone who's got signs and symptoms of a DVT but also has shortness of breath now, is that PE? You know, those are the sorts of ones where suddenly it's useful. If we've got a completely negative scan, PE becomes much, much higher on the list. So that's where it's useful. It's kind of a bit of a CT without contrast in your pocket. But if you end up with some B lines, you have to know how to interpret it. So I've been searching for anything that can be a little bit more specific about B lines, and really the only publication that's honed in on that is the one that Volpicelli came out with, I think in March. So I'll show you very quickly. It's all in his additional information stuff. So yeah, the link is down there. April, sorry, he came out in. So he brought up this principle of the light beam sign. Now we use the term light beam for describing big B lines anyway, but what he means, oh bollocks, sorry, recording still. What he means is a sort of band of confluent B lines coming off a little stretch of pleura, which might be at that stage just before it's got inflamed and had that roughening. So this is the early stages of ground glass opacification forming on CT scan. So before the pleura becomes rough and interrupted and has those really, really obvious sort of viral pneumonia changes, and we've just got B lines to work with. But often this is just as they come to hospital, sort of day 5, day 6. So they can be a bit tricky. Hopefully there's something that suggests infection in the history, but if not, this appearance, so this is a little band, you can see there's a few centimeters of pleura that's affected. It's not coming from just a point, and it has this on-off effect. So it sort of flashes up and then disappears, flashes up and disappears on the background of A lines, A profile. So that's much more specific for this sort of viral pneumonic process, whereas with pulmonary edema, it's just all over the place, and they traditionally are supposed to be quite evenly spaced apart, aren't they? They say 7 millimeters or 3 millimeters of it's intra-alveolar fluid. So I just wanted to show that, and then there's just this chart. This was from a study a couple of years ago looking at so the incidence of B lines and what they were associated with. So we know that elderly people have more. We've traditionally said sort of more than 3 B lines or three or more B lines within a rib space is pathological, and less than that is probably normal. But most young people don't have any, or they'll have just 1 or 2 right at the bases. So, you know, have a growing suspicion. You can't say it is, but have a growing suspicion if you're seeing, you know, 3 in every rib space or 2 in every rib space. So under the age of 18, or even under the age of 64, pneumonic processes are still by far the main reason for having B lines on an ultrasound scan. So we can be pretty comfortable that it's less likely to be things like pulmonary edema there. It does start to become a more predominant condition over the age of 64, but underneath that, the odds are still that it's an infective process. So just have that to back yourself up, but looking at the pattern, looking at the distribution, looking for pleural effusions will just help support your causes. So that's the only way I can say I'm making it a little bit more specific, but it is a bit more nuanced than just looking for B lines. You have to sort of know how to distribution, what sort of stretch of pleura is involved, and then those additional little bits. Anything else that you're doing differently, Michael?
Yeah, we're mostly using it for cases where the X-ray is normal or equivocal, as Ash was saying. And then if you see the classic COVID changes, you know, integrating it with your pretest probability just to improve diagnostic accuracy. We thought about using it as a kind of streaming tool, but we decided not to because we've got quite good testing now. We're doing like lateral flow testing and the point of care LIAT testing, so we get pretty quick answers from that. And so we didn't think it added that much in terms of streaming. So yeah, it's mostly useful.
Yeah, I think we've kind of missed the benefit for that now. That was when we really didn't have anything, and there's a lot of resource that needs to go into it. You have to train up a lot of people, and also, you know, show you're being safe, so continually audit this. And we're always trying to fight our battles, you know, fight for PoCUS to be taken seriously and us to be trusted. So I think at this stage where so a lot of our patients are coming in with tests from the community, so it just has a lot less applications. We could be using it to, you know, screen out asymptomatic people, but we know it's not quite as sensitive in that portion of people, and the risk of sort of overdiagnosing is just too high for the sort of layout that we have.
Yeah, and then there's this theory that like, early on in the disease process, the viral replication is more in your upper airways, and you've got a higher viral load and you're probably more transmissible, and later on it moves down into your lungs and you might be sicker but actually less transmitting. And so like in the first 48 hours of illness, when lung ultrasound is less sensitive, you might actually be more transmissible. So to use it as a rule out for streaming, I think you should potentially be putting the highest risk patients, you know, in those days with vulnerable patients. So,
but then there were some studies saying that the lung ultrasound's positive before the PCR is positive as well. So I'm not quite sure which of those two is real, but it seems like it can't be trusted at that in those sort of first 3 days, that sort of early stage.
Yeah, but I totally agree with what you were saying. Like if you've got a hypoxic patient with a normal lung ultrasound, just like if it's a hypoxic patient with a normal chest X-ray, the same kind of principle. Like makes you a lot more suspicious for things like PE.
Yeah, I think the lung ultrasound can certainly reduce the diagnostic momentum for COVID, rather than diagnosing COVID, because it's quite an easy diagnosis to make in most cases. But it can just make you think a little bit more about whether there's an additional reason for them presenting.
Yep.
I haven't seen the Volpicelli light beam very often. That's probably why it's very specific, but I don't know if you see it quite often. I mean, the most common thing is that you get this patchy B-line distribution that looks very different to the diffuse homogeneous pulmonary edema B-line distribution, and you obviously don't get those pleural line changes. But I haven't seen very many of those typical light beams.
I think the sort of bands of B lines I see quite a lot. I think that sort of classical one that he showed there was maybe a bit earlier than what we see the patients come in with. Usually they've sort of stepped over into having some subpleural consolidations by the time they're poorly enough to see us. So maybe see it a little bit more. But the young chest painy COVIDs, I see that quite a bit in. So I have seen a few, but it tends to be day 4, 5 early on. I feel like most people are coming in day 6 to 10, something like that.
Sure, yeah, that makes sense. And I guess the one thing that I didn't quite mention, but it's probably quite important given that we're in a second wave and we'll have a third wave and maybe even a fourth and a fifth wave, is that we've certainly started seeing patients that have had COVID 3 or 4 months ago, have come back in with gallstones and have still got some residual lung ultrasound changes. So what happens to your lungs over time is still a little bit unclear. So I guess if your patient isn't presenting as COVID, some of those changes could be old changes now. And I think that's something to bear in mind for people that are going to go out scanning.
Yeah. And I recently did a talk on COVID complications and looking at the sort of CT resolution of the lung changes, even just with viral pneumonia, so non-COVID pneumonias, they could take 18 months and there will still be sort of fibrotic bands and things like that. So you're likely to get sort of patches that look like atelectasis or big B lines in a lot of these patients who had radiological changes back in March, whatever. So yeah, absolutely, and I'm sure it will last for months, if not years. Which can make it, definitely not a screen at all. I'd like to make a disclaimer. Yes, the speed of sound in tissue is 1540. I can't read my handwriting. And then the talk that I was looking at today also had 1040. So we just reinforced our falsehood. So 1540 meters per second is the speed of sound in tissue. We'll have to do the whole talk again.
Yeah, start again. Okay, start again and go.
Any questions from the audience? It's been fun chatting to my colleagues here, but any of you guys want to talk about it?
They're all just on mute because they've gone to eat their dinner. They're just all mute.
That's okay.
Are you actually there?
Timo's here.
Put your videos on, you can see if you're actually there.
Cool. Okay. Enlightening. Right, so I'd say give it a go. I don't think lung ultrasound is particularly difficult, and we lots of people in your apartment, I'm sure, have had a go at it recently. So I'd just give it a go. Just be very careful with cohorting people on the wards saying they have COVID. If you're only going on the ultrasound, so the medical director gets very angry. Okay.
Some comments in the chat.
Cool.
Thanks, guys.
Thank you, guys.
Yeah, thanks very much.
Just before we go, if anyone's got any other suggestions that they want in the next session for advanced or basic, we will take recommendations now. Otherwise, we will enforce something on you.
And thanks again to our eminent speakers, Dr. Kolkloff and Dr. Matthies. Excellent talks. That was really nice.